Started. Thank you all so much for being here today. I'd like you to join me in welcoming Dr. Manali Patel, who is an associate professor of medicine at Stanford Medicine and a staff oncologist with the VA Palo Alto healthcare system. She earned her medical degree and master's in public health at the University of North Carolina at Chapel Hill, followed by internal medicine residency, hem-onc fellowship, and several research fellowships, in addition to obtaining her master's in health services research at Stanford. Dr. Patel directs a research program that focuses on improving equitable delivery of value-based cancer care. She uses principles of community-based participatory research in her work and is the principal investigator of multiple externally funded awards, such as the California Initiative to Advance Precision Medicine, the Patient-Centered Outcomes Research Institute, and the National Institutes of Health. Her expertise lies in designing, implementing, and evaluating new models of care delivery with academic, community, and VA oncology practices aimed to improve patient experiences with care, clinical outcomes, and reduce unwanted health disparities, unwanted healthcare utilization and health disparities. Dr. Patel also serves on several national committees focused on improving cancer care delivery and value-based care. She is the past chair of the ASCO Health Equity Committee and the current chair of the ASCO Serving the Underserved Task Force. So Dr. Patel will be delivering the Iris Fisher Lectureship today. The Iris Fisher Lectureship was endowed by Dr. David Fisher in 1999. Dr. Fisher has been involved with Yale School of Medicine for nearly 60 years. He was the first medical oncologist in the New Haven community and remained in private practice for 30 years before joining Yale's Cancer Center in 1993 as a volunteer and full-time in 1995. When Dr. Fisher's wife, Iris, was diagnosed with sarcoidosis, an incurable disease of the heart and lungs, treatment decisions were weighed and balanced against the impact the therapies would have on Iris's personal well-being. It was Dr. Fisher's hope that this lectureship would serve as a lasting memorial to Iris while providing an educational opportunity for physicians and staff for the benefit of patients. We are grateful to Dr. Fisher for his generous support, and we are grateful for Dr. Patel for delivering this lectureship today. Please join me in welcoming Dr. Manali Patel.
Thank you. I know Michaela from many eons ago, and so it's nice to see so many familiar faces and also so many new faces that I've known more recently. And thank you all for joining in person. I really want this to be more interactive, so please ask questions, interrupt me, push up against the bar. I really want you to think outside the box and really push me in terms of what I'm presenting today. So I'm going to give a brief background of my work and why we started a lot of work in supportive cancer care delivery. And then I'm going to focus on multi-level stakeholder engaged research, giving an example in supportive cancer care delivery, which are aspects of palliative care, and then focus in on the why for me. I love being first. How many of you all love being first? We're all competitive, so I know many of us want to be first. I actually don't like being first in the amount that we're spending for healthcare. And why are we last in terms of our spending for social services? How many of you all saw this over the weekend? NPR? Yep, I see some folks saying yes. For all that money we are inputting into healthcare, why are we doing so poorly? And many will say, well, it's our COVID-19 policies. I'm sorry, the trend was beginning long before COVID-19. And so could it be this long-term shortchanging of social services? And then you look at cancer, which is all of our areas of expertise. This is completely unsustainable. How many of you all drive on the highways? When there's a pothole, that comes out of the same bucket of congressional funding as paying for healthcare. So if you're utilizing most of the gross domestic product on healthcare expenditures, we have limited for other social care expenditures. Limited funding to fix our roads, limited funding through K through 12 education, you name it. And despite all this money we're investing into cancer care, especially at the end of life, we see really horrible care. How many of you all have had a patient that was unaware of their prognosis when they were nearing their death? Many of our patients are experiencing undertreated symptoms. We also see this large shift, and I've heard about it. What you all are building here in this network is actually quite different. But out in the real world, outside of Connecticut, we see this huge shift of care from community-based settings into these large hospital conglomerates. And then we also see tacked on facility charges. So not only is care then centralized and away from people in their communities, but then it's also more expensive for the same product. Fascinating. Then my own area of expertise is disparities. We see persistent disparities by socioeconomic status, race, ethnicity, demographic characteristics that are largely due to the lack of expenditure for social care services that continue across the continuum. How many of you all have seen this graph? Robin Yabroff, good friend of ours, the American Cancer Society. I love this U-shaped curve because it shows you, and I know when I walk away, they're not going to be able to hear me on Zoom, is that right? But what's wonderful about it is it shows you this peri-diagnostic phase. There's this huge uptick and uprise that coincides with when patients have the worst experiences with their care. So not only when they're becoming diagnosed and going through the flurry of activity during diagnosis with treatments, but then also at the end of life, you see this sharp uprise. And it doesn't matter how long your survival is, you see this same pattern. And I think she revised this most recently. So the only thing that's changed essentially is the y-axis. It's much more expensive now. How many of you all know of Don Berwick? He challenged us in 2008 and said, he was a MedPAC commissioner, and thought about these disruptive innovations in healthcare. Why is it that in every other sector, when a new technology is developed, the costs come down? You think about the first iPhone, first CT scanner. But in medicine, it tends to be the opposite, where we don't have very many interventions that achieve this whole triple aim of improving population health, bettering patient experiences, and reducing total costs of care. You may see some interventions that may do 2 out of the 3, but not interventions that can achieve all 3. And he challenged us as a nation and said, if we really want to ensure that our population is better overall, and that we have some GDP left for social care, we really have to tackle this cost problem in healthcare, but also think about our interventions such that we're not decreasing the quality. I know Michaela knows this, but community-based participatory research. Raise hands if you know this about it. Okay. I learned a very critical lesson. So I went into medical school at UNC, and I'd really hoped to be a global practitioner. And I went into the traditional medical school training, and it was right across the street from the School of Public Health. But there was little interplay. I love UNC. I'm a Tar Heel born, Tar Heel bred. When I die, I'm a Tar Heel dead. But what I hated about medical school and what led me to think whether medicine was really in it for me, is this the right career, was that there was this lack of focus on prevention, but this huge focus on treatment. And I'm going to talk a little bit later about why potentially that may be in this consumerist society. And so I did my master's in public health. I took a year off, right? It was actually a very difficult year in the public health degree space, and did my practicum. So as part of your thesis, you have to write up a practicum. And I decided to go back to a community that I had worked in as an undergrad in Honduras. And as one of the key principles of community-based participatory research is this understanding that communities know the problem and they also know the solutions. And so as researchers and as budding medical physicians, we always like to do what I call global tourism, where we go in, we take our ideas, hey, we have this great idea, we're going to input it in your system, and not really knowing if that's really what the community needs. And so I thought I would really focus on diabetes, food insecurity, housing insecurity in this community. But instead, I heard from the community members what the main problem was cervical cancer. Women dying from cervical cancer. Now, this was long before the connection with HPV had been made. And what they said was, we have lots and lots of women dying from cervical cancer. Makes sense now. This was a migrant farm working population. They were coming to areas of North Carolina, going back and transmitting HPV, and thus lots of women were dying. And there was no screening. So I came back to the United States and I said, oh my gosh, what did I get myself into, right? I know nothing about cervical cancer. I'm an internist, right? Budding internist. So I came back and asked 2 budding OB-GYN med students if they would help me. And we went back and we heard from the community members. And they said, how do you screen for cervical cancer? Why can we not provide the screening? How ingenious. What differentiates me as a medical student from community members in the community? How can we, the question came up, well, we don't have the infrastructure. We've got sticks. So we made wooden stirrups. We have headlamps. And just as easily as we were trained in medical school to conduct pap smears, so can community members in their own community be trained. But who's going to pay for it? So the other principle of public health is the number needed to screen and the number needed to treat. And it was a very eye-opening experience for me to think about following the dollars if you're really going to make an intervention sustainable. That's great. As a UNC practicum, I've got a small bucket of funding. I can come here, do some pap smears, go back. What's going to happen when that funding is gone? The program ends. So to create a sustainable model, you have to engage other people in the community. Where were people going when they were diagnosed with cervical cancer? Well, they weren't diagnosed. They were actually going to the local Planned Parenthood and dying in that facility from symptoms, from other disease burden, from bleeding, and all of that cost was being borne by this facility. Guess what? I bet they would pay for the number needed to screen, to do all of the samples, evaluate all the colposcopies, and also conduct the colposcopies. Now, over 20 years later, guess who's teaching UNC students in the summer how to do pap smears? Sustainable model, not dependent on us. And the community knew the solution. Had I gone in with my own idea, it would have turned into a very different project that may have been completely meaningless. I went to Stanford. I'm looking at Pam because, Stanford is a Silicon. How many of you all have been to California, Silicon Valley? It's like community-based participatory research with a twist is this design school. So many of you have an iPhone, right? What was ingenious about Stanford, right? They are always trying to create ways to make money. So this huge startup culture. So they created this school then that would teach people about how to make companies that would get more market share. So you involve the consumers, right? If you have a product like an iPhone, maybe go out and co-design it with the people that would potentially buy the iPhone, such that then you're going to design a product that's going to be more applicable to other people, like the people that you designed it with. But if you think about what they do, it's actually the same concept of listening to consumers and building this out. Now, if you think about supportive cancer care and trying to achieve, actually, not even supportive cancer care, but just care in general and healthcare in general, there has to be an alignment of goals and also financial payment models across each of these groups. But where we're lacking in healthcare is that there's always this misalignment. And so I'm going to walk you through one example where we focused in on that uptick of the U-shaped curve, the right side of the U-shaped curve. Because at the end of life, many patients are experiencing unwanted acute care use, unwanted healthcare expenditures at a very high cost. So that's low yield if we want to try to achieve the triple aim. So we started off with this combined algorithm of the design school and the community-based participatory research methods. So we asked patients and caregivers, which is clearly what you would do with community members in CBPR. What were the barriers and the challenges? And what would some solutions look like if you were to create a system focused on end-of-life cancer care delivery that looked very different than the one that you're currently in? We also did the same with clinicians. And then we included a critical piece that we learned from the design school, which was this idea of payers as well as policymakers. And surprising to me as a wide-eyed, bushy-tailed fellow who was kind of in my little realm, really not thinking about the financial misalignment, what I heard from clinicians and from healthcare systems was this is the right thing to do. But if we were to reduce emergency department visits and hospitalizations, like what hospice and palliative care are meant to help with, goal concordant care, usually patients will choose not to be in a hospital setting at the end of life. There goes our bottom line. And I was shocked. But it made sense. And so we heard from communities that they wanted to be a part of the product. They want to co-design the product. They are often not involved in palliative care efforts. And we heard from patients that it was easier to talk to people in the waiting room about their prognosis and their questions about end-of-life cancer care, what questions they should ask. They were getting activated in the waiting room by other people in the waiting room, peers. And they felt less comfortable talking about these issues with their clinicians. And then the clinicians, of course, said lack of time and also some considerations that palliative care and hospice weren't quite ready. They weren't quite ready, right? Patients may not quite be ready for some of these services. And so we had these same players, same stakeholders, create a model where we, long before the ACA in 2012, we had them design an ideal approach that would align their goals and also would be aligned by financial value. And what they landed on was training a community health worker or a peer support navigator to help them understand concepts of values, goals, preferences outside of our 15 to 30-minute visit in the oncology clinic. They also had wanted someone to call them. And again, this was long before ePros, right? ePros had not been up and running at this point, 2009, 2010. By the time we published this, right, it was many years later. But they wanted people to call them and ask them about their symptoms rather than reactively calling us when their symptoms were too far advanced. And then again, before the COVID pandemic, we heard that and had talked with individuals in Australia and the UK who were receiving chemotherapy on mobile vans. Yet what we're doing in the United States is we're centralizing care and actually removing sites that may potentially be more convenient for patients. You could leverage telemedicine and deliver low-risk chemotherapeutics in essentially rooms that are half the size, quarter of the size, which is what was also being done in parts of Nebraska in the VA with a telemedicine oncologist that was leveraged in to ensure no complications. And now that makes it less disruptive, but at the time, this was really a no-go. Many people thought that the third model was really not very idealist. It was a little bit too idealistic. And so we decided to test this. What we heard from clinicians was we need to see a randomized control trial before we're willing to engage in any of this work. And so this was essentially our framework, was if you were to remove many of the barriers in the yellow, potentially you could get to improving patients' understanding about advanced care planning. You could also improve symptom management by proactively reaching out to patients. And then hopefully ultimately improve goal concordant care, which many of you know is hard to measure. Many in the palliative care space, there's a lot of debate about measurement of goal concordant care and how one would do that, given the fact that goals change so often. And you certainly can't measure it once patients have already passed away. And the surrogates may be able to help you, but it's really unclear. So this idea of being able to achieve goal concordant care is really addressing something that may be hard to measure. And so we tried again as a fellow, I thought, let's test all three together. But I already told you, most people said no way to the last one. Like telemedicine, what? On a mobile van, no way. Right. We're not giving chemotherapy in places that are not in our infusion center. But shockingly, I also heard from places that we are not going to have a lay health worker, community health worker, talk to our patient about what a surrogate decision maker is. We don't want anyone to talk to our patient about advanced care planning. You're going to remove hope. And so we also got a lot of pushback on even testing the community health worker advanced care planning intervention. So I thought, well, let's split up the model. We'll test each one individually, and we'll go to a place that's more integrated. So the VA, I was a clinical fellow there and really never thought about having a full-time VA job. But what I was really shocked by is many of the innovations happen in the VA. Telemedicine, we've been using it for decades in the VA. Many of our PACT models of utilizing peer support were developed at the VA. And you can get innovations if you pair with operations. You can really jumpstart these out-of-the-box clinical ideas and get them into practice very quickly. And there's also this alignment of finances because they serve as a payer. So there was a desire by the VA to improve not only veteran experiences, to improve their health outcomes, but also to lower costs. So there was a clear alignment, and they said, yes, let's do it. So we trained this lay health worker to conduct a series of segments, either by telephone or in person with patients. And so the first segment was really just discussing and developing rapport. The next few segments over time, it was a 6-month intervention, would be about tailored messaging about goals and values and preferences and giving people the time they need to make these decisions. So that means starting way up front from when people were actually having conversations about this at a point which made some oncologists very uncomfortable. So we would start at diagnosis, if not before diagnosis, before the first oncologist visit, discussing this as part of usual care. And the last was helping patients with advanced directive completion, completion of documents like the Stanford Letter Project, which wasn't in existence at the time, developed by B.J. Periacoil, using Rebecca Sudor's work, but really ending up really completing those documents, but also getting the tailored support they needed. And it's easier if you just hear this. Let me see, I'm not sure how the video will work. Let me see if I can. Let's see. Let's see. Is there anyone that can help me with the I think anyone can help me with the video? What was that? This one?
One more. There.
Let's see.
Is your primary goal to fight crime to make sure it's out of your system?
No, not really.
Is your primary goal to fight crime to make sure it's out of your system?
I don't want to die. Bloomberg meets regularly with healthcare coaches with even share.
Stop sharing.
Stop sharing. Sharing. Share.
Go share.
Share. Right there on the left hand corner. Share sense. And just click that again. That's right. Just mute that. Okay, now you can share.
Okay. Thank you.
You gotta hit it again. Look, that came off. No, that's fine. That's fine. Just go to share screen. Share sense. Now you can select if you want to share it. Then you go share here.
Perfect. Thank you. That's what that is.
Is your primary goal to fight this, to make sure it's out of your system?
You know, I don't want to die. I got lots of things to do.
Blumberg meets regularly with healthcare coach Labiba Sher. A compassionate ear, Sher's role is to provide the big picture, to help patients think about how cancer treatment will fit in with the way they want to spend the rest of their lives.
Can I learn a little bit more about what it is that you want to do?
Well, I want to do some more traveling. I want to spend time with my kids. I'm getting a little emotional.
What are they getting from you that they don't get from anyone else?
Well, they get someone who's actually helping them through their care. With me, they're actually discussing things, what they're feeling, what they're going through, what they want to do. What they understand is their prognosis.
I just decided not to go through the treatment.
Patients like 47-year-old Rafael Arias. A former Army police officer, Arias is suffering from a recurrent sarcoma and has already lost a leg to cancer.
Right now, we're just trying to take advantage of the fact that I'm still here and trying to do some things while I can. Why have you decided not to have chemotherapy? It made me sick, and within a week, we had to stop it. So as difficult as it was, I just decided not to go through with it. You want to have the highest quality of life for as long as you have life. Correct. With the little bit of time that I have left, my wife and I have plans of maybe doing some things before my departure.
Is your primary goal?
And that was essentially a 7-minute clip. So Al Jazeera America had heard what we were doing. And before we had any results back, they thought it was so fascinating that someone who is not trained medically was having what would otherwise be considered a medicalized conversation with patients. Why do we medicalize these conversations? Patients really do need the time to be able to engage in this work. And while I had clinical equipoise as to whether or not it would work, we certainly knew that there were facets like these stories where she had spent so much time with patients who would have otherwise in my clinic had received chemotherapy and gone through with it. What patients then said was, we didn't want to disappoint Dr. So-and-so. It's very complex. And so we decided to test this in a randomized trial. We heard from oncologists that we were potentially causing harm and that we would potentially, by this intervention, cause people to die faster. So we had to dispel that myth. We also wanted to see if it was feasible. Can we improve goals of care conversation? So we randomized patients stage 3 and stage 4 disease, also with recurrence of cancer, agnostic to disease, into this intervention that you just saw clips of versus usual care. And we measured goals of care documentation as well as patient experiences and total cost of care. We randomized 213 patients in this consort diagram. You see 108, 105 respectively in the control group in the intervention. It was block randomized by cancer diagnosis. And because it was in the VA and we had claims data, we could conduct an intent to treat analysis. So despite loss of follow-up, we were actually able to complete the entire ITT for the patients that were initially randomized. And what we found was shocking to me. This is goals of care documentation by the oncologists, many of whom were opposed to this model, many of whom didn't even know that it was happening. It was in the background, no interaction between the community health worker, lay health worker, and the oncologist. But yet, patients were being activated to tell their physician, I want to have goals of care document. And can you print it out? because the community health worker was helping to engage patients in these conversations, saying if your oncologist doesn't bring it up, you need to bring it up. And we found that this also led to improvements in advanced directives, as we anticipated. If you have tailored assistance, you're more likely to be able to complete the advanced directive documentation. And this changed over time. We had to dispel the myth that because you have an advanced directive, that you can't change it. You actually can change it. It's a living doc, it's meant to be a living document. And so we would update the advanced directive as people's life course changed. We found that patient satisfaction went up. This was using the consumer assessment of healthcare providers and healthcare systems general survey. The question of, would you recommend care on a scale of 0 to 10? How satisfied are you with your clinical team? 10 being a very high satisfaction, 0 being low satisfaction. And what we found over time in the blue line is that the intervention group improved and the control group declined. We did not cause harm. So unlike Jennifer Temmel's model, which I'll show you, we improved palliative care, we didn't find a survival benefit, but we dispelled the myth that we were making people die faster. But what we showed was at the end of life, there was better care. 95% reduction in acute care use, almost doubling of hospice utilization. And the baseline in the VA is high, as you know, because we can provide hospice concurrently with care. Why that's not closer to 100%, there are many issues, but we were able to actually double that to close to 100%. And we found in the last month of life, not only were total costs, median total costs lower, but you see that variation. This is amazing to me, is how narrow that variation is. You've removed the outliers. One outlier can do you in. That variation is really what we want to try to improve upon. And so at the same time, I wanted to test the symptom management model, right? The community health worker conducting this proactive symptom assessments. It wasn't a novel idea. Kurt Kurlenke and the VA had been conducting this with a nurse. What was novel about it is that you would have a lay health worker, community health worker conducting this. It was novel at the time because we really had very limited proactive reach out to patients across the United States to assess symptoms. And so I went to Southern California, and interestingly enough, I had been giving presentations about this model, hoping that we would find pilot test partners. Most of the time I got the door slammed in my face. It, again, was before the ACA. So payers did not want to be involved in something that seemed like, thanks to Sarah Palin, coined a death panel. Even though we had payers at the table designing the model, they did not want to be involved in it. And so CareMore, the woman that was in charge of CareMore at the time, Labiba, she ended up having breast cancer. And so this story resonated with her on a personal level. And she said, look, if you can find an oncology practice that's willing to help, we will do one piece of your model. Actually, we'll do the advanced care planning and we'll do the symptom management. Again, we didn't have the data from the VA because it was at the same time. Well, we found an oncologist practice that was willing to do the symptom management piece. Again, did not want to have anything to do with the advanced care planning. And they said, we need a per member per month fee to do this. This was before OCM, the oncology care model, which now reimburses or had been reimbursing for some of these services. And now there's a new OCM. So this was before that time. And it was kind of unprecedented for a payer to be providing a lot of this upfront payment to many of these practices. And then we did a back of the envelope calculation, and there is a misalignment. All this work that we do in our clinics to try to save patients' symptoms, try to improve their symptoms, it's going to reduce emergency department visits and hospitalizations. And if it's not an integrated system, guess what? You've input a lot of effort into something that you're getting no reimbursement for as a practicing oncologist. So we took that model to CareMore and said, look, you're getting this much. If it were to work, which we think it will, you're going to get X percentage, right? We think that we're going to save 20% net implementation costs. So if we think that you're going to save the money, it's important that you pay for the intervention. And we're going to make it a low cost intervention using lay health workers, not a nurse-led model. And you can create a shared savings model where a third will go back to the patient a third will go to the clinical team, and a third will go into you. And they agreed. The oncology practice then had one more negotiation. They wanted all market share. Every beneficiary from this Medicare Advantage group was going to go singly in Fullerton to this one clinic. CareMore agreed. So we tested it. Lay health worker was embedded, paid for by CareMore Advantage, Medicare Advantage, embedded in the clinic, did weekly phone calls with patients. Initially, we started with patients that had advanced stages, and then we moved more upstream to patients with all stages after a couple of years because the clinic really liked it. And we showed they would review symptoms using ESAS. How many of you all know ESAS? Edmonton Symptom Assessment System. It's a scale of 0 to 10 with multiple symptoms. I think there's 9 or 10. And then there's also an other category, 10 being worse symptomatology and symptom burden, 0 being less symptoms. And what we found was essentially for patients, and we built this into the protocol, that any score of 4 or above, or that changed by 2 points from that assessment, would then get triaged and reviewed with a nurse practitioner. The nurse practitioner FTE was also covered by the payer. And then we decided, wait a minute, the nurse practitioner is reviewing all of these symptoms. Let's build out an automatic referral with waived prior authorization, because we're working with the payer, we can do that. For symptoms that are escalating, they would go directly to palliative care and bypass the nurse practitioner review, or they would go to the behavioral health services because we were also screening for anxiety and depression. In a cohort study of 800 patients, so the cohort of patients that were receiving the intervention versus a matched cohort in the year prior, we found for Edmonton Symptom Assessment System survey assessment tools that essentially the mean scores reduced over time in this 12-month intervention. The control group went up. And we also found, not surprisingly, better anxiety and depression. No harm. So we also can't replicate Ethan Bosch's work. But we did find, again, very similar reductions. And again, this was for all patients, not just patients with advanced stages, but reductions in acute care use and reductions in total costs of care. And for the cohort of individuals that had died, we found very similar findings as the VA, where at the end of life, it was better care, better experiences, and lower total costs of care. With, again, drawing your attention to the variation in costs. And so we just finished a randomized trial of both interventions. So layering the advanced care planning and the symptom management, which is always how it was supposed to be. Right? You can't keep people out of the hospital if you're not, and that may be their goal, if they're not adequately and appropriately managed for their symptoms. So they really go hand in hand. And so we conducted a randomized trial. Now, this was a different patient population. It was privately insured. So we did it in the VA with the advanced care planning intervention, with the Medicare Advantage group, which was mostly older Hispanic Latinx adults in Fullerton, California. And here now it was a younger population that were privately insured. We randomized in the acute care use, and the healthcare use goal was our primary outcome. We randomized a total of 128 into the intervention and conducted an ITT. And we found, lo and behold, even better reductions in acute care use. And this was not just at the end of life, this was at 12 months. I think there was a very small proportion of patients that had actually died in this study. And so consistently, we found robust effects that were consistent across multiple studies. And better yet, we also found that there was a net savings, where a lot of interventions, like I talked about before, tend to not save money. They may be effective, but they may not save money, is because your implementation inputs are too expensive. But we had a very low cost, high touch, patient-centered solution that utilized perhaps people that can reach patients better than we as clinicians can. And that was a tough pill to swallow, I think, for many of us that think we are the greatest thing next to sliced white bread. But we really do. It takes a team. And what it did was it enhanced provider relationships with their patients. So we have another study where we looked at across all the stakeholders what their experiences were. And we polled the oncologists across 12 different sites. And overwhelmingly, many have chosen to continue utilizing this model because of the benefit for not having to do, when your patients are better managed from a symptom perspective, you get that opportunity to really connect with patients on a different level. And so many of you know that equity is really why I went into medical school. And taking evidence-based interventions and plugging and chugging them into community settings is not a one-size-fits-all. So a labor union organization called Unite Here. How many of you have heard of Unite Here? Oh, great. So Unite Here essentially provides a labor union organization for hourly low-wage workers. At McCormick, we all go to McCormick, most of us. Many people that work in McCormick are part of this union. Hotel workers, casino workers, restaurant workers, taxi drivers. And unfortunately, because they are hourly wage workers, they don't have health benefits. So as part of the union, what they decided was that they were going to skim off a very tiny fraction of people's paycheck and put it into a health fund. And so the health fund really wants to provide high value care, meaning very high quality at low cost. And they have the union backing them, right? They're part of the union. The union is and the members of this union very much trust Unite Here Health. There's this engender trust because it's one and the same. And so they had heard of the work and they knew that at the end of life, for many of their hourly low-wage workers, they were having poor experiences, especially as they were dying. And so they asked us if we could embed our model. And so I'm glad I did that public health degree, because I took a step back and said, okay, well, let's see how we would embed this model in your population. So we created a community advisory board. So I polled people from Atlantic City and Chicago, as well as the union members and the union president. And can someone take a wild guess as to what a patient told me when I talked about this intervention, about a community health worker, a healthcare advocate, reaching out to them to talk about advanced care planning? I didn't know either. I was actually very shocked. What they said was, you try having a conversation about goals of care when you're worried about where your family is going to live and how you're going to get food on the table for your family. You're asking me to do something that I think is going to hasten my death, then who is going to provide for my family? Eye opener. So guess what? We tabled the intervention and we focused on addressing health-related social needs. We integrated that. We didn't table the advanced care planning, but we integrated the health-related social needs first and foremost. And we used community engagement to build partnerships with industry. One issue is transportation. How are people going to get to and from their clinic visits? Well, guess what? Lyft can provide free transportation. Better value, better quality, lower costs if people are adhering to their treatments. People have no place to live. Local housing authority. Let's build in places for people to live while they're getting care. Let's think about ways to invest in social care. Because then, as an organization, Unite Here Health has individuals with lots of diseases, not just cancer. Cancer is one slice. If we invest in social services, we are likely going to do better for not only our members, but also reduce costs. And so we built this in, and then we also heard from Unite Here Health that there were some crooked groups and some oncologists that perhaps were not providing the highest and most evidence-based care for patients. And that is an area of research for me, where we know patients by race and ethnicity, socioeconomic status, where you go determines the care you get. And so making, for example, the Yales out in the community is a fantastic idea, because providing evidence-based care is a way to overcome many of the disparities. It's not due to patient-level factors. I know we go there. It's actually due to what people are receiving once they're diagnosed. And now we've shown study after study after study that if you get the care that you need and the care that's evidence-based, Your outcomes are the same, if not better, than more affluent white individuals who usually do much better. And so we picked through, I went through their claims. I went out to Atlantic City and Chicago as a fellow multiple times, looked over claims data and tried to identify the highest performing providers. And in Atlantic City, there was an MD Anderson clinic. It was very costly, but it also provided evidence-based care. And so the union said, okay, Manali, let's redesign the benefits. Okay, what do we need to do? And I said, let's not reduce market share. People want a choice. I want a choice when I am diagnosed with cancer. And that's what we heard from the community advisory board. You want a choice of where to go. But so don't remove the choice and have a narrow network, but rather expand the network and give people an incentive to go to the higher providing provider. So let's waive copays. For people that choose to go to MD Anderson in the clinic in Chicago, your copays are waived. You still have choice, but you also get additional funding if you choose to go to this, you have less out-of-pocket costs. So as part of this study, the union asked us to do a randomized trial, which was actually very shocking to me. But they really wanted answers quickly. And so we randomized patients. Everybody got that free benefit of free cancer care services. So as part of usual care, every patient received that extra benefit of waiving costs. But all the other patient population that were randomized received the added benefit of the community health worker screening for health-related social needs, conducting advanced care planning, and symptom management. We randomized 160 across Atlantic City and Chicago. And this just goes to show, I don't want to go over all the details, but a very different patient population. Younger patients, more females, high proportion of Latinx, Black patient populations, and Asian subgroups, which made us have to translate all of these documents and to also hire a lot of community health workers from communities that spoke the patient's preferences of language. And that was costly. Unite Here Health did it. Again, very low annual household incomes and very low educational attainment. And what we found using the functional assessment of cancer therapies general was that patients' health-related quality of life improved. Makes sense. If you're screening for health-related social needs, you're likely going to have better quality of life. How much of this was from the other interventions is what I get asked all the time. Why does it matter? Shouldn't we be doing this in our practice? I think so. And parsing out one piece from the other doesn't really make sense, especially when you think about the patient population. And then if you look at the similar reductions in emergency department use in hospitals, but you see that there's a higher mean with this patient population. Very complex patient population utilizing acute care services more so than patients in our other studies. But over all stages, so again, this was all stages of cancer, I guess 12-month intervention, we found reductions in total costs of care. Is this scalable? We're now launching a 24-site cluster randomized control trial. To me, doing usual care is kind of unethical. We know that palliative care and these services work. So comparing to usual care is really kind of a no-go for me anymore. And so we've now started embedding technology-delivered tools where the same exact tools that the community health worker uses in his or her interactions with the patients will receive passively in the control group. I also want to make sure that we've got every single type of facility where people receive care included. So we've got community practices, we've got integrated systems, we have the VA, academic systems, and also our safety net hospital systems. Years later, Don Berwick wrote another article, and I'm almost done, so we can take questions, in 2023. If you all have time, just a couple of months ago, I would love for you to pick up that article and juxtapose it against what he wrote in 2008, because it's very sobering, sombering. Even the title, The Existential Threat of Greed in the United States Healthcare System. And in that article, it makes me question, are we going in the wrong direction? Is it worsening? Because now we see, how many of you all have seen what ASCO has done for wellness, burnout? Of course, our ASCO president knows. You can close your ears when I talk about this. If we don't get at the root of the problem, everything else is a Band-Aid. The problem is the healthcare system, the way that it's financed. I did not go into medicine to be a paper pusher and to argue with payers about prior authorization for services that I know work. Nor did I go into medicine to make a huge buck. And I know that may be different, but I also don't think that as a society, capitalizing off of people when they're sick is where we want to go or where we should go. And now hospices. Sadly, profiteering. Why this is shocking to me, it's really not, because we're part of the American ecosystem where there's this desire to want to capitalize. But it really makes our jobs harder as physicians to think about what we were trained in medical school not to think about, but it's impacting all of us. This is the why for me. Why do I keep going? Even though it seems like, the system is a big wave and crashing us all over, I really don't feel that way. I'm actually still bright-eyed and bushy-tailed and naive. How many of you all know Paul Farmer? Humanitarian. And for me, this is the why. Health really is a fundamental human right. It's not something that if we live in the right neighborhood, if we have the right parents, if we have the right education, if we speak the right language, that we may or may not be able to attain our highest health possible. The why also is because we see change. The ACA was huge. It opened up the door to being able to take away this idea of death panels. We actually get reimbursed for having conversations that should be part of the fabric about how we deliver care. But also, remember that site that I told you in Fullerton that said, no way to advance care planning, we'll do the symptom stuff if you give us a bunch of money? They now are advertising on their website this program as part of one of their critical services. And CareMore decided to pull out. They said, we're not paying for it anymore. But guess what? This oncology group is continuing with it now and has expanded across 3 states. A couple of months ago, we trained all of the health advocates at Unite Here Health. So all of the health advocates across the United States, Las Vegas, New York, Boston, the food industry, they were all trained on this model. And I firmly believe in advocating. Policy change, we always forget about the outer bucket, but it's so important to think about how to advocate for change. So with community partners, we were knocking on the door in Sacramento every month saying community health workers need to be reimbursed. And so now, as a Medi-Cal benefit, as of July, the work that my community members and the community health workers are doing are now reimbursed. I have a lot of other projects now focused on that other side of the U-shaped curve, really trying to improve equitable evidence-based care delivery. And for me, it really is people over profits. And I think all of you in this room, because you came to this talk, number one, really believe the same thing. When you think about the people at the table, we've got the governor's office. You can see the big Capitol. We've got the county Department of Public Health. You think about who's at the table, who even knows that a table exists, and who's not there, who may not know that the table exists. Bring them all together and you can create sustainable interventions like I talked about in Honduras. And that's it. That's a wrap. I think we have a couple time. This is our lab. And so if anyone wants to check it out, please, we've got a bunch of other studies ongoing. And then certainly some questions. Yes, in the back. Oh, thank you.
One of the beauties of community-based practices is really gets to know.
Yes.
Really the whole value of that. Did you identify any particular cultural barriers and or facilitators within the communities that you engaged with?
Very good question. So the question, did everybody hear that? Maybe for online folks. The question was, Did you, with community-based participatory research, really knowing the communities, and if we identified any cultural barriers or facilitators in the communities that we identified with? So yes, and I'm really glad that you asked that question because there were some considerations, especially amongst some of the Asian patient populations, about patients maybe potentially not wanting to engage in discussions, but that their caregivers would. And so we expanded the intervention to allow for cultural humility. If that is how that is in their family, who am I to say, I want to talk to the patient directly about what the patient wants? That is how, and especially in my family, the same goes in my family. We want the patient to be engaged, but is that how, if that's how they've set up, and that's how they've been, that is part of their culture and the fabric of their culture, we should try to begin to tweak our interventions, again, using that same concept of not going in with blinders of thinking that this is the way this intervention should be, but rather thinking about how to co-design the discussions. Facilitators was faith-based. So in Atlantic City, we found community partners that were faith-based organizations across multiple demographic groups who really came to charge and would talk about filling out 5 wishes in their sermons on Sunday. We found Hindu priests discussing advanced care planning. We provided them with the materials. And so they expanded that reach and normalized these conversations long before we had to even engage. Very good question. Did that answer some of your questions?
I mean, the analogy about technology, you never go buy cost.
Yeah.
That's what good healthcare. How do we change capitalistic model we see in healthcare versus every other kind of technology sector? Like, why are they so different? Is it fear? Is it lack of information? Like, why are they so different? And how do we kind of approach the bigger problem?
Good question. So the question was why, in the technology sector, there's this desire, please correct me if I'm wrong, there essentially you can make products that can then lower costs. But in the healthcare sector, we're not there yet. And it's all because this misaligned incentives. If you think about the different players, we haven't come together to align. Consumers really drive change. And so what we really need to do is galvanize like we are in these communities and start thinking together and collectively about how to change that. I hate to go there, but a universal payer system, you see how it works in the VA. And there are challenges, but every study we've done in the VA and outside of the VA shows that people within the VA have less disparities when they get care within the VA system. And now with the Mission Act that allows our veterans to receive care in community-based facilities, we see that when they use community-based facilities, their outcomes are worse. It is a way to financially incentivize and to align goals. Not to be a reductionist, but that's one example. Yep. Next question.
A comment and a question. So the comment is that I worry a little bit about putting patients in the middle of the cost situation.
Yeah.
Partially because the costs are in many ways artificial. And I think the real solution is, of course, that we should have coverage for everyone.
Yeah.
And then we should work on figuring out the cost. And I fear that some people will just say that's just too much money for me, and for maybe the wrong reasons choose not to get care. The question I have though is, to what extent, I know in at least one of the studies, there wasn't interaction between the community health worker and the medical team. To what extent in other situations have you had the contact between those two?
Yeah, that's a good question. So the question was, to what degree does the community health worker engage with the clinical teams? I think in the ideal scenario, you want a highly functioning team where there is communication across both. Unfortunately, and the majority of the sites have chosen that, even if they haven't chosen that initially. They've come around to really engaging the community health worker as part of the team. Where we've seen struggles is in that example in Atlantic City and Chicago, where the oncologist really did not want to be involved at all. And so we said, okay, we're going to do it with the payer alone. And there was limited communication, but we also want to make it such that patients are activated. These interventions, the proactive symptom assessment, I think should be longitudinal, but the advanced care planning, you really want to give patients the tools to be their own advocate. And so in those situations, and most of our studies are really just limited with that intervention, you see, which I didn't show, is an enduring effect of the intervention long after the intervention has ended. And so we just looked at the VA study now 10 years later, and we found actually really big differences at the end of life for the patients that died, perhaps indicating that the skills that patients were learning are like riding a bicycle. You want patients to activate for themselves. And so in those situations where we don't have the well-functioning team and the communication, we have the community health worker activate the patients to call their clinician and make sure that these symptoms are addressed. So they say, I'm going to get off the phone with you. You're going to call your clinician. You're going to hang up. I'm going to call you again in an hour and see if you did it. And so it helps the patient to then begin to be their own voice, so that they're not reliant on someone else mediating that relationship. And the reason that's important is because cancer is one part of what a patient may be diagnosed with. And so you want them to have skills that are going to supersede the small, narrow piece of medical conditions that we all are seeing at the surface and treating.